Hello, everyone, and welcome to today's webinar, Trauma Verification's August Q&A web conference. Now for audio, please dial in using the phone option for best sound quality. Now just go ahead and select phone call, enter in that dial information that's displayed for you. Now that being said, I would now like to introduce Molly Lozada, Trauma Verification Program Manager.
Thank you. Thank you everyone for joining today's Trauma Verification Q&A web conference. And on today's webinar, it's actually just going to be myself. We have, based on some feedback we received from our participants, we have revised how we are going to do our presentation going forward. And the section on site visit, scheduling, and process will only be covered every alternate month or every other month, if you will. So that way it's not repetitive for some folks, but will be available on past webinars and also next month's webinar for those of us or those of you that are new. So just a small change to our slides going forward. With that being said, we're going to go ahead and get started. Again, I just want me to read some housekeeping based on our rules, our policy. Continuing education, to qualify for CE, you must attend at least 15 minutes of educational content. An email will be sent to all attendees who qualify for CE within 24 hours of the webinar ending with instructions on how to claim those CE. If you have any questions regarding CE or any questions to today's webinar or further future questions, you may send them to the cotvRC@facs.org. The goal for today's webinar is to interpret the standards outlined in the Resources for Optimal Care of the Injured Patient manual to ensure that hospitals have an understanding of the criteria to provide quality care to the injured patients, understand the processes and standards involved in an ACS trauma verification site visit, and how following these will positively impact the quality of care of the injured patient at your center. So with that said, let's get started. Again, just some housekeeping things. Copy of the Orange Book is available online to be downloaded as a PDF. And for anyone who is new to our webinars, even for some current trauma program managers, just please be advised that our manual does not get reprinted. It is the original one from 2014. Any new updates or changes to the document will be noted in our change log, the one down at the bottom here, Excel spreadsheet, and that can be filtered by level, CD, date of new edition, etc. The clarification document is just that. It's just clarifying some standards that may be a little bit nebulous and not super clear on what is expected. And these documents are released on a monthly basis. So if you have not received one in the last month or in the past and want to start receiving them, please contact us at the cotvRC and we'll add your name to our distribution list. Typically, the distribution list, just so you are informed, is to the trauma medical director and the trauma program manager and any registrars we may have previously received communication that they wanted to be added to that, but typically it's the TMD and the TPM. But again, if you want to be added, go ahead and let us know. Again, just some resources for some new folks. Recording the webinar has its own site, stakeholder, which I'll cover at the end of our presentation, just an update on that, but you can still provide feedback, FAQ, some tutorials for some new participants or even existing participants if you want to get some updates on scheduling your site visit. And again, the participant hub is the account center, which is what Rachel was covering, but for some of you who wasn't here last month and want to schedule a new site visit, we do still accept the paper, but we are directing everyone to use the participant hub to schedule your site visit online. That way you would not have to deal with emailing us a copy of the application, so you can do that from the participant hub. All questions are pulled directly from the questions submitted. There have been no edits made to the content. If your question is not answered in today's webinar, it's because we may need more information or receive multiple responses or similar questions to that, but we will follow up with you if we need to clarify anything further following the presentation of this webinar. Announcements, the next verification Q&A webinar is scheduled for Wednesday, September 19th at 12 p.m. Central Standard Time. The deadline to submit questions is Thursday, September 6th, and we apologize for the short turnaround. There's a couple of things going on in September. As many of you know, we have AAST towards the end of the month, or actually second week to the end of the month, so that is a huge impact on how we're scheduling this call or this webinar. And the same may be true for October and November, October being our clinical congress meeting. It's a huge meeting that the college puts on for trauma surgeons and other guests. And in November, as many of you know, it's the TQIP conference, and here's a save the date. Many of you probably are aware of this. Hotel registration is now open, and you can register for hotels and the conference itself, and also for some web or what we're calling pre-conference workshops. So I did this little grid here so folks know how they align, the pre-conference conferences align Wednesday, Thursday, and Friday. And what I wanted to mention on this slide is topic is being offered on an alternate date than optimal, which is great for those trauma program managers or trauma medical directors that want to take the optimal course. And during the optimal course, if any of you have taken this, we always make reference to, hey, you should go take the topic course because it will help with understanding your performance improvement process and how to do that. Well, this year they've done a great job and now are offering the topic course first. And it's an all-day course the day before the optimal course. So again, I'm not promoting that you should do both, but if you're interested in doing both, they are now on alternate days versus doing it on the same day, which was a little, it couldn't be done. And then there's some other courses going on as well that are very important as well. And that's all available online. NTDB call for data is open and is, they're gonna accept data through October 1st, 2018. During this call, they are accepting admission year 2017 data. TQIP participants are not expected to participate in this call for data and should allow their should follow their regular quarterly data submission as you are notified by email. Centers with upcoming consultation or verification visits will not have to pay to submit. For more information regarding the annual call for data, you can email the TQIP folks at tqip@facs.org or go on to this website noted below. So just a couple of updates on the PRQ. Just because Megan, myself, and Bumi are seeing some challenges with the reports that are coming back from the site visits, and we're going to hopefully try to do some more education around this and hopefully add some language to the PRQ itself so that folks can understand what we are asking for and not cause some confusion. And I think the part that's causing some confusion is, and this piece that I'm going to cover is now on the online application form through the participant hub. So when you do access that, there are a couple of questions we ask, basically what type of visit you're seeking, what level of your trauma center, and the piece that is confusing folks is the facility treats, the question on facility treats what type of patients. And what this really means is it's not based on the type of visit you're seeking, but the type of patients that were admitted during your reporting year. So the reporting year you are using for your upcoming site visit is really what we're asking. And it does not impact your verification. We're just wanting to make sure that the PRQ is set up appropriately, and that way you don't have the site reviewers during a site visit asking, well, where's your pediatric data when you only told us you're admitting adult only, and then Megan and Boomy will follow up with you after the site visit and causing a little bit more work and a little bit more angst. So we're hoping to catch a lot of this before the visit takes place. And some of you who are preparing for an upcoming site visit know that we are also doing some validation on our PRQs just to ensure that the questions are answered appropriately and not triggering false deficiencies. So we are trying to do that going forward, and we may do a soft validation where we're just looking for triggers such as this particular question or other areas that continuously give us challenges. So again, if you're a trauma center that it's just recently submitted an application or are in the process of a site visit, and in this particular field it's blank or it reads adults only, we are going to reach out to you. If you have not done that already to us. If it is blank or if there's some confusion on this, please reach out to us at the COTVRC inbox. But I am having a staff person review the data and just reach out to you folks to ensure that it, if it does say adult only, that means that you are not admitted or you did not admit any pediatric patients during the reporting year. But if you had one patient or two patients, we do want you to select adult and children, and that way the PRQ is set up to display the pediatric section, but only a component of that is what we're asking you to complete, because we do want to capture the children that are admitted to your trauma center. So again, if it's causing a little bit of confusion, please reach out to us. Again, another area that, and this is for level 3 trauma centers, if you happen to notice that this question is not marked as a yes or no, please reach out to us so that we can answer that question, and that way, again, the PRQ is programmed to display specific questions for the type of trauma center you are, level 1, 2, or 3, the type of patients you admit, adult only, children only, and adult and children. And for a level 3 trauma center, this is another component that if you check yes, there's questions that are going to display in Section 8, and if you check no, there's questions that won't be displayed in Section 8. So again, another staff person will be reviewing this, validating this, and reaching out to you. But if you catch this before we get to you, please reach out to us. That would be great. We would be grateful. CMEs, I know we've talked about CMEs quite a bit in the past month, and there's been the new change, but I want to let everyone know that we have made the updates to the online PRQ, so you will not see the CME questions populate except in the appendices, and again, the Word documents have been updated as well, so they're available for download at your convenience. So if some of you have downloaded those, I don't know, a year ago or more than a year ago, and are working on it, that's okay. You can continue to work on it. And I had asked before that you skip those CME questions. That's perfectly acceptable. But I just want to let you know that we have updated that. And again, just as a reminder, CMEs, external CMEs are required for the trauma medical director at adult trauma center and pediatric trauma center and or pediatric trauma center, and anyone who's gone through the alternate pathway. Liaisons are not required to have external CMEs, but that may change with the release of the new book. Again, I'll cover some of those topics at the end. The other section that is causing some confusion, if you will, or we're having Megan and Boomy reach out to you guys, is on the Section 2 data tables, and hopefully this will help some trauma centers in figuring out how to read these tables. And for table number 5, and which is causing some confusion, we're only asking for admitted ED trauma visits during the reporting year. And again, those are trauma patients who meet the NTDS inclusion criteria or that of your trauma center's inclusion criteria based on your state guidelines. And the colored colored text boxes is what we're asking needs to match. So if you have an admitted patient in table number 5, we're asking for the breakout in table number 7. So, you know, that's by service. Again, we're hoping that this table helps some of the folks understand how we want the breakout to be, but you may receive a call or an email from Megan and Boomy just asking to align the numbers. And this question actually goes back to the table, and it talks about patients that are brought to the ED by EMS and trigger a beeper activation, both a major or minor activation with trauma team arrival based on suspected injuries concerning mechanism or physiology. After their workup, the patients are stable enough to be discharged to home from the ED. These patients are not admitted to the hospital with discount toward the volume criteria. And we've had a number of questions about this, and I am going to be working with TQIP to align our definitions in the next couple of weeks. And if something changes from that, or even a clarification that comes out of that, we will definitely announce that to all the participants in either our newsletter or next month's webinar or in an email blast. We'll get the word out there to folks who are having a visit in the next couple of months, for that matter. If the patients were worked up and stable to be discharged from the emergency department and were not admitted to a service, and remember, when we talked about this, the table here, we're talking about table number 5, admitted patients, and then you have to break it down in table number 7 by service. These patients would not count towards the patient volume criteria, so we're looking for admitted patients. To meet the requirement and complete the online PRQ data tables, as I mentioned, we want the number of admitted trauma patients that meet NTDS inclusion criteria or your trauma center's admission inclusion criteria. So again, just go back to this table here to align the numbers, and hopefully that would help. So general questions. Hybrid operating room is access to the hybrid OR required at a level 1. The trauma service and ortho service already have dedicated trauma OR rooms, great for this trauma center. There are no requirements regarding access to the hybrid operating room. I suppose you can, at your own facility, you can establish some guidelines should the trauma OR or the dedicated trauma service or the OR rooms are occupied. I guess you can establish some guidelines where, you know, they may have access to the hybrid, but that's, again, that is going to be defined at your trauma center. The social worker, if you do not have a dedicated social worker, what would be the best practice to demonstrate commitment to the trauma program? A social worker is not required in our standards. The best practice to demonstrate commitment to the trauma program would be for the social worker to be made part of the trauma team or included in the trauma team. And I put in here, at a minimum, provided updates in regard to activities within the trauma program, so that way they're aware of what's going on with your trauma program. In addition, the social worker should document his or her evaluation in the medical record. So you can make them part of your team or provide them updates to what's going on in your program. Question about non-trauma admissions versus non-surgical admissions. Please clarify the difference between non-surgical admissions and non-trauma admissions. What should we be looking to reduce? And in regards to non-surgical admissions, what specialty services are considered surgical? I know this confuses a lot of people. Hopefully what I put on here can clarify some of this, but I think non-surgical admissions are always going to be a topic for discussion because I think they're just, people have different definitions of what they are. Non-trauma admissions are those patients that do not meet the NTDS inclusion criteria or your trauma center's inclusion criteria as a trauma patient or / admission. Non-surgical admissions are those patients that do meet NTDS inclusion criteria or that set by your trauma center as a trauma and do not require surgical intervention. Non-surgical admissions may be admitted to the trauma service, neurosurgery service, or the orthopedic service. Orange Book revisions for level 3s. Would you expect the ACS to better define the role and requirements for staffing specific? I'm sorry. For level 3s, would you expect the ACS to better define the role and the requirements for staffing specific to the TPM data support. For the Orange Book revisions, we expect to define the roles and requirements for staffing at all levels, not just the level 3. Level 1, 2, 3, the adult and pediatric, we will be working on doing more staffing requirements if possible. I do want to mention that in conjunction with the trauma surgeons who are working on the revision process, that we actually have established nurse partners from the Society of Trauma Nurses, and this has been something that we've worked with them in the last several years, and they have identified who those nurse partners are, and they are actual members of the work or the revision work group. So for every chapter that is revised, there are possibly 2 to 3 nurses in that work group to give their input, and those nurses are from all levels, level 1 or level 2 or 3, and also from pediatric trauma centers. So the work groups, the revision work groups are very multidisciplinary, where there's multiple people. So I just want to let folks know that if you're concerned about having your concerns heard, the nurses are part of that work group. Research form, on the new Excel research form, what is considered multi-system. There's also a category for multi-center, and I do want to apologize for the confusion. The word is used interchangeable by us here at ACS. The term multi-center and multi-system are one and the same for us. It is defined as a collaboration between any 2 or more trauma centers, where the authors and co-authors or co-authors must be from the trauma centers involved in that collaboration. I am looking for some guidance. I am preparing for our consultative visit, and I'm getting charts together for the medical records review. Do I only pull records from the reporting period? If so, I will not have the required number of charts for each category, or do I go back as far as I have to get the requested number? If that is the case, I will have to go back several years. For example, to pull 30 deaths, I will need to go back to the middle of 2015. I just want to be sure I do what is required, or what I should. So the short answer is no, you do not need to go beyond your reporting year. For the on-site visit, the medical records are for the reporting period. If you do not have the requested number of medical records for a specific category, for example, we ask for 10 of your spleen charts, pull what you have available at the time of the visit. If it's 0, then it's 0. If it's 1, it's 1. We don't want you to go back 3 years to pull medical records. We want to just look at what you have managed during that reporting year. The other piece that does impact the surveyors or the reviewers on the site visit is if you happen to have a medical record that has multiple injuries, or it's a polytrauma, do not copy that medical record. Just have just the one record, and you can flag it or tag it as a multi-system injury. I can't tell you how much our reviewers are just displeased with that, having that chart copied in multiple and have it in multiple categories. It just causes more confusion because, if you're not aware, the reviewer picks up that case and they're just looking at the case. They're not looking at just the injury. They're looking at the entire case. So if it's a polytrauma or a multi-system trauma, that's what they're going to look at, and they're going to document it as or write up their case review for the report in that manner. So you don't want to the 2 reviewers duplicating the same data for the same patient. Pediatric medical records for level 1 pediatric trauma centers. Do you pull the patient charts for only patients less than 15? The short answer is no. We do want you to have charts for both sets of patients. If you do have patients, I don't know, to 18 years of age, or some centers have it to 21 to 25 years of age. So you can pull both sets of records. We just want to make sure that if you are going to pull your 15 to 18, then your 18 to 25, whatever that age may be at your trauma center, that you flag those appropriately as being older than the 15-year-olds. But for purposes of completing the PRQ, the data that we ask for in those tables that I referenced up earlier, we do want the data to reflect the the younger than 15 years of age data, so that way it is compliant with the criteria set forth for level 1, 200 patients, and for level 2, it'll be 100. So we would just want to make sure that it's, that the reviewers can see that. I had a question about, could you cover another hypothetical timeline if verification expires on October 1st, 2021, the date of application, data year, visit date. So I did a timeline here, and hopefully it just comes over well in your presentation or in your screen. You kind of have to work backwards, and it's really based on your center's expiration date and when you want to have the visit scheduled. So you have to work with both those. Ideally, all visits have to occur on or before your expiration date. So you have to work from that point on and backwards. So once you've established what your expiration date is, when you want to have your visit scheduled, which may not necessarily be in the same month as your expiration date. In this example, I used September. I used September as the scheduled visit date, and you would then count 14 months back from that point on to then submit your application for a request. So that would put you into June or July to submit the application of the previous year, and then your reporting period would be based on either July 2020 to 2021, and you have a little bit of wiggle room there where you can use June to June or July to July. You don't want to go anything beyond that, because then reviewers get a little worried that the data is not concurrent. So again, you just want to work backwards, and then your reporting year has a 2-month lag from the date of the scheduled visit, and that does account for submitting the PRQ 30 days in advance. So again, hopefully this timeline will help this person. Alternate pathway criteria: non-boarded orthopedic surgeon is cleared for alternate pathway in previous site visits. Do you have to go through the process again? The answer is no. If that person was approved and it's noted in our files, an additional on-site alternate pathway review will not be required. However, documentation must be provided at the time of site visit for the following. That is the external CME, as previously mentioned, or it could be a combination, CME, external CME, or an IEP process, or a combination thereof. And also the PI assessment by the trauma medical director to ensure that patient's outcome compare favorably to other members of the trauma panel. Backlog data. We have a backlog of data in 2017, but are concurrent in 2018. With this results in a CD if 2017 isn't completed by our 2019 visit. So this is a little tricky, so I just made a reference for verification purposes in completing the online PRQ. It would not be a deficiency if the data is concurrent for the reporting year, because that's what we're looking at the time of the site visit. We're not looking at data previous to that. With that said, and based on this particular instance, if it may impact the quality of your data or what you're reporting to TQIP. And again, when this person references backlog, that could take on different meanings. So I don't know if backlog means that it's not in the registry and maybe not reviewed for PI purposes, or it's backlog meaning they don't have the data in the PRQ, in the registry. So it can take on different meanings. But if it's not in the registry, then that's what I was referencing to, that it may impact the reporting to TQIP. So again, this person may need to look into maybe their PI process and entering that data. We are scheduled for a visit in February 2019 and now considering PEDS verification for the same time. Is it too late to do? It is not too late. If you intend to seek pediatric verification at the time of the adult verification, let us know as soon as possible. As I mentioned previously, the PRQs are programmed specifically based on the level that you are seeking and the type of patients that are admitted. And in this instance, in this case rather, it's a combined trauma center, so it will impact your PRQ if you've already gotten access to it, which you should have. So let us know and we will make that update at our end, so that way you have the appropriate PRQ, and also for scheduling purposes that you have the appropriate members on the review team, because you'll need a pediatric reviewer on your team. How vulnerable is a program if there are multiple staff changes, trauma program manager, trauma medical director, surgeons, and this will depend on your trauma center and how strong your program is. And there's different ways to look at this. So if the TPM and TMD are both new to the institution and there is a visit in the near future, it can be months away or within the year, it may pose a challenge to learn how the program functions in that sort of a time frame. Usually if there are staffing changes, it's either one, the trauma medical director or the trauma program manager who are new to their role. We would generally recommend a consultation prior to the visit. That is, if time permits, because consultation length of scheduling that is the same as scheduling a verification visit. So you have to allow for time. So we have had instances where there's been a new TMD appointed actually on the date of the site visit, so that happens, but usually that is someone that's already on the trauma panel. But in cases where they're both new to the program, meaning they've come from another institution or just, have never been at an ACS verified trauma center, that may pose some challenges, but I certainly don't think that you ought to cancel a visit due to that unless you foresee that there are some critical deficiencies, some critical type 1 deficiencies. Then you should contact me and we can have a conversation. I like to at least have a conversation with trauma centers before canceling a site visit, just to see what, if anything, I can do to help with that situation. For level 2 trauma center verification, is the facility required to have neurointerventional radiology or transfer agreement? So the ACS does not have any requirements in regard to neurointerventional radiology. This may be something new that is covered in the revision process, but currently we do not have any standards around neurointerventional radiology. So we're going to go ahead and move on to CD-related questions. When there is a lapse in pediatric anesthesia coverage, is this counted as diversion hours or services unavailable, no hours? So I'm going to follow up with this person because I have some concerns based on the question itself. And again, sometimes it just needs a little bit more clarification. But if we're talking about, what this really says, pediatric anesthesia coverage, I'm assuming that, I guess I can't really assume what's going on, but I'm going to follow up with this person. But if there is a lapse in pediatric anesthesia coverage, this would count as diversion hours. The program would need to meet the criteria for diversion as noted below. So I guess my questions would be, what exactly is lapse in pediatric anesthesia coverage? Does that mean the anesthesiologist is not available? Is there staffing issues? What kind of things are causing some lapse in pediatric anesthesia coverage? And again, you have to notify the trauma surgeon in the process, identify when the hospital's resources are not available, or and notify the EMS agency, and then provide status updates, notify other trauma centers if there's issues, review occurrences through the PIPS process, And again, there is a requirement tied to that diversion. So if it's something that's consistently happening, that is going to impact your percentage on being on bypass or divert. And again, that's something you want to look at and monitor through your PIPS process. Our attendings in pediatric trauma have all done ACLS training. We are a level 1 pediatric trauma center. Do they need to refresh their credentials formally in ACLS course before expiration, or if they are actively participating, does that meet ACS requirement? So I did a little table here, if you will, members who require current ACLS and those that have taken it or who have had to take it once in the past. So those who require current ACLS is the trauma medical director, physicians who work in emergency departments who are not board certified in emergency medicine, but are board certified in family practice, internal medicine, advanced practitioners who are members of the, advanced practitioners on the trauma service and the ED service who are members of the trauma activation team and who evaluate and resuscitate trauma patients. They require current ACLS. Members who do not have to have current ACLS, but have to have taken it once before. And I will add a clarification to this. Trauma surgeons have to have taken it once. Physicians who work in the emergency department who are board certified in pediatric emergency medicine or in emergency medicine have to have taken it once. Advanced practice providers for the trauma service and an ED service who are not members of, or they can be members of the activation team, but don't play a role in the evaluation and resuscitation. Actually, they don't have to have ACLS, so that's a clarification for this slide. Does the OPPE for ortho and neurosurgery need to be completed by the specialty liaison, or is it acceptable if it's done by the med staff and the TMD reviews it? I have a clarifying question from last month's webinar when discussing OPPE for the specialists. Is it okay to have one OPPE for the entire group and evaluate them overall as a group, or one form for each of their names listed? So the first part of this question, it is acceptable for the OPPE to be completed by med staff as long as the trauma medical director and specialty directors, that being for neurosurgery, ortho, emergency medicine, etc., have reviewed and signed off on the content. And then to answer the second question, each provider must have their own individual OPPE process. If you want to put it on a big, massive spreadsheet for everyone, that's acceptable, but we're not looking at it from a group's perspective. We're looking at it from each individual surgeon. Trauma activation limited tier, can an NP, nurse practitioner with ACLS, arrival time to a limited tier activation count as the trauma surgeon's arrival time? The short answer is no, it cannot. The NP's arrival time for a limited tier activation cannot count towards the trauma surgeon's response time or take the place of the trauma surgeon's response time. So let's be clear on that. With that said, the NPs with current ACLS status may be the responder to the limited tier activation based on your own institution's guidelines for the type of patients that that person can respond to. However, there must be guidelines in place for when the trauma surgeon is expected to respond at bedside for those patients that they're responsible for seeing at bedside. So again, you can have criteria established for the limited tier where you have the nurse practitioners respond, and then you also have to include criteria for when the trauma surgeon is expected to respond to the limited tier as well. You have to have those two incorporated into your guidelines. Risk-adjusted benchmarking report. We had a question asked, will CD 515 be viewed, actually it's CD 15-5, be viewed in relation to the risk-adjusted benchmarking reports being late? So there is no deficiency on whether or not a trauma center receives their TQIP report. So let's make that clear. The CD will be imposed when the trauma center does not participate in a risk-adjusted benchmarking process. So the idea of having the report is for the reviewers during a site visit is so they can ask questions on how the trauma center is using the TQIP report to enhance the current PIPS process, your current PIPS process, or how the trauma center is identifying areas for improvement and what corrective actions they've taken to improve those areas, or what they've done in the past to work on those areas, and also how that data is being shared with possibly non-trauma personnel or other trauma team members like your neuro, ortho, your EM, and your hospital quality insurance process. So again, the CD is not based on whether receiving the report or not. Reviewers have been told or instructed to ask trauma centers on how they are using their TQIP report. So they may ask you these questions, and again, it's not does not hinder on a CD. They just want to know how you're using that data. Non-surgical admissions, we had a question, are the trauma program director and the trauma program, the trauma medical director required to review on non-surgical admissions, or only the non-surgicals with an ISS greater than 9? So for trauma centers that admit more than 10% of trauma patients to a non-surgical service, the expectation and that requirement is that the process that the trauma medical director and the trauma program director or manager in either case, is that the PIPS process, that they must review all those greater than 10%. So it's all of them, not just those less than 9 or greater than, with an ISS greater than 9. So again, for trauma centers that admit more than 10% of trauma patients to a non-surgical admission, the PIPS process must review on non-surgical admissions. Please clarify the inclusion criteria for non-surgical admits. Is the 10% after exclusion of fall and surgical consults? The trauma, again, I'm just going back to what we're calling the inclusion criteria, which is the NTDS inclusion, or that established by your trauma center. If the patient meets the inclusion criteria, it's best to admit to the trauma service. That's what we recommend for the first 24 hours. And I've given some examples for a patient who's 43 years old, fell from a 10-foot ladder with a small subdural external abrasions, and who is diabetic. And if you look on here, so the best process would be to admit to trauma with a neurosurgery consult, or they can admit to trauma for the first 24 hours and do a tertiary exam, acceptable, transfer to family physician with neurosurgery consult. So ideally, if you're admitting them to a non-surgical service, that you have a consult, a surgical consult for those patients. Trauma program manager clinical experience had a question on how is clinical experience in the care of injured patients defined. I think I've received a couple of questions on this, and I'm not sure if it's from the same trauma center, but the ACS does not define clinical experience. So the qualifications for what clinical experience is going to relate to is going to be defined by the trauma center. So I mean, that can be patient care. They've had experience with patient care, or again, you're going to define what that clinical experience is going to be. And again, I know we had a question about defining roles and staffing or experience for staffing. And I think this is one area where we are going to hopefully make it more clear going forward in the next revision of the manual. 30-minute response time example for neurosurgery. In past webinars, you stated penetrating injury to head with altered mental status. Can you please provide your definition of altered mental status? So I got this from our neurosurgery liaison. So penetrating injury. So penetrating injury to the head with an altered mental status is defined as any depression in consciousness, sleepiness, drowsiness, lethargy, coma, or any confusion or disorientation. Basically, anything that isn't normal thinking or level of consciousness. That's how our neurosurgery liaison describes altered mental status. Board certification for anesthesiologists. As far as being board certified, does that include routine trips to the OR, or is that only for patients emergently going to the OR and the physicians on call? Also, for example, if the only available anesthesiologist for an emergent situation is non-board certified, can they start the case and have a board certified anesthesiologist take over before the 30-minute response time? So just want to clarify that that criteria in the book about having board certified anesthesiologists on the trauma call panel was changed to only having the liaison be board certified. Everyone else on the anesthesiologist call panel who's managing or involved in the trauma panel, or with the trauma panel rather, are not required to be board certified, or at least we're not speaking to that. We're only requiring the anesthesiologist liaison to be board certified. So hopefully that answers many of the questions you have above. So the criteria, as I mentioned, has no impact on the other anesthesiologists who take patients to the operating room for either emergent or non-emergent cases. So again, the board certification is only applicable to the liaison, or who you have identified as the liaison. Operating room staffing, does adequately staffed include an anesthesiologist and if your facility does not utilize CRNAs? So there's 2 CDs tied into this response. So the composition of the operating room team will vary by institution. This may include, but is not limited to, the following: operating room nurse, scrub nurse, surgical tech, surgeon, anesthesiologist, CRNA, etc. Any one of these team members may begin preparing the room and the patient within 15 minutes while waiting for the anesthesiologist to arrive. That is CD 1114. If the center does not utilize CRNAs or residents in that case, the anesthesiologist must be in-house 24 hours a day. So they're expected to be in-house 24 hours a day. So this actually was from July's webinar, the ICU patient to nurse ratio. And I had mentioned that I was going to go back and get further clarification. So, and I did. So clarification following discussion with the VRC chairs regarding the July webinar question on the patient to nurse ratio of 2 to 1 in the ICU, and whether the intent was meant for patients while in the ICU unit /4 and those waiting for a bed in the emergency department. So that was the question asked, that if that extends to the ICU unit and those waiting for a bed in the ED. So after having, speaking with my chair, the VRC chair has determined that the guidelines for the patient to nurse ratio for the ICU patient while in the ICU and or in the emergency department, those that are waiting for a bed, will be set at each individual trauma center, which is how many of you have done that. So I just want to bring that back to the group, that that will be determined by your institution or your trauma program guidelines. Hospice case, I understand when a patient is discharged to hospice care, I need to include them in my deaths. My question is for the patient that was seen and treated for an ortho injury and discharged to hospice and returns to the hospital 3 days later after a fall and has a head bleed and is admitted as the family wants to withdraw hospice. She is discharged the next day back to hospice. Does she count in my death numbers twice? So I know I've talked about hospice case, and I know in the review agenda we say that the reviewers want to review a hospice case, and they do. They want to review at least one, whether it's a death or not a death. So what I do want to clarify is the expectation and what we're asking for in this situation. So if the patient was transferred to a hospice service within the hospital, some centers have that, or a facility or a hospice facility outside the hospital, the expectation is that the care leading up to the transfer is evaluated through the PIPS process by the trauma medical director and the trauma program manager. That's what we're asking for. And if there are any issues found with the care that led up to them being transferred to hospice, that is reviewed that is part of your peer review, that is reviewed at the peer review meeting. So again, the expectation for these cases is that the program, trauma medical director and trauma program manager, are reviewing the care that led up to that patient being transferred to hospice. Not necessarily their death. Unless their death occurred on your service, then yes, it would count towards your deaths. But if it occurred elsewhere, once the patient's discharged and a death occurred, then we're not asking you to review that case unless you've received some feedback and you want to review that. That's perfectly acceptable, but that's not what the expectation is. Peer review meetings, there is a push by some of our liaisons to combine both the trauma operational and peer review meetings. What is appropriate format? So what I've stated is that these meetings should be kept separate because there are differences in both meetings, and one there is a requirement and the other one there is not a requirement, at least not in the Orange Book there's not for the operational piece of it. So again, the purpose of the multidisciplinary peer review meeting, which requires attendance at minimum 50% by liaisons, that's a requirement, and it requires minutes, is to improve trauma care by reviewing selected death cases, complications, and sentinel events with objective identification of issues and appropriate of responses. The operational meeting does not require an attendance by the liaisons and is typically attended by other hospital personnel, med staff, and it is also attended by the trauma program. The exact format may be hospital specific based on what's come out of the peer review that you want other people to know, or it could relate to any other trauma-related hospital operation or functions going on, and that's under operational meetings. So ideally, you want to have these two meetings separate because there are some confidential things that are discussed at the peer review that may not necessarily extend to other members of the trauma team or possibly other personnel, hospital personnel. Trauma-related education. Is it mandatory to have all RNs taking care of trauma patients? Trauma educated. We use a lot of travelers with no trauma experience. So again, this is something that's going to get or be built into the revision process. We've had a lot of concerns over not having specific nurses in specified areas require education. So we have one standard that talks about nursing education, and that's just for the trauma program to have a mechanism in place to provide trauma-related education to nurses who are caring for trauma patients. With that said, the ACS does not have a requirement for what education specifically nurses must have. However, if there is a low percentage of trauma-related education for nurses who care for trauma patients, let's say in the ED, or in the ICU or in the PRQ, what may result from that is an opportunity for improvement. So the reviewers will make that, put that in the report that is an opportunity for the trauma program to provide more education for the nurses, but it does not hinder or does not infer a deficiency. So you will not be cited as for one. Alcohol screening. What is the starting age for the patient for alcohol screening for adult trauma centers? I heard 12, but it's not documented anywhere. 2, does the screening have to be BAC or it can include other screening tools such as CAGE? In other words, a type 2 deficiency is for less than 80% BAC not done on screening, not done. So a lot of questions around this, and I do want to clarify this is not a new standard. What we try to do with this alcohol screening is add a threshold to make it less burdensome on trauma programs. As the standard reads in the book, it says all trauma patients must receive a screening. So we've changed that to 80% of those patients must receive a screening. So I just wanted to clarify that piece of it. So in response to this, question number 1, the trauma center will define the starting age to screen their patients. Some trauma centers have defined it as early as 12 years of age. Others have done it as young as 9. So that will be dependent on your demographic area. And again, it's not a requirement. So the age cutoff is not a requirement. We're just going to hold you, trauma center, accountable to the age that you set forth. So if that's 12, 9, 8, that is what we're going to hold you accountable to meet the standard. Question number 2, the trauma center may use other screening tools such as CAGE, BAC, etc. There's a list, and the PRQ. The deficiency is not based on the type of tool used to screen the patients. It is based on the number of admitted trauma patients that did not receive a screening. So that is what the deficiency is going to be on. Research regarding Chapter 19 and research was it recently decided that option number 2 is no longer available to a level 1 trauma center. That is not correct. Option number 2 is still available as noted on page 146 of the Orange Book. It's still available for adult and pediatric level 1 trauma centers. What we did is we updated the online PRQ in the research chapter to align better with the Chapter 19 questions, or standards rather. So we just made a little enhancement to flow better, if you will, in answering the Chapter 19 segment. So just a few questions on CME. Do we need to show proof of board certification at site visit for revised CME requirement, or will dates of certificates on PRQ suffice? So we don't ask for dates on the PRQ for the certificates. What we are asking trauma centers to demonstrate compliance with the change in the CME requirement is to ensure that the board certification period extends through their expiration date and not when they first were board certified. So again, we've made updates to those in the PRQ, in the appendices noted here, 1, 2 through 4, 4 through 9, 13 and 14. So we've clarified that we are only asking for the expiration date of when they became board certified, and that will be compliant with the CME change. Again, if you have any questions about this, please feel free to follow up with us following this webinar. Please review CME requirements for trauma, orthopedics, anesthesia, and ED physicians. Again, just to clarify, only the trauma medical director, an adult trauma center, or the pediatric trauma medical director, and any surgeon who has previously undergone the alternate pathway review, or any that are going through the alternate pathway review, are required to have external trauma-related CME. Except for the alternate pathway, they can have a combination of external, internal, one or the other, or both. CME board eligible surgeons and physicians, as I mentioned, if they are currently boarded, we just want their board's expiration date. If they are board eligible, the reviewers know that it is based off of when they completed their primary training, so make sure that is in there. Of when they completed the primary training, and then in the field where it says what type of boards they have, you would just simply put board eligible, and you can put BE for board eligible, or abbreviate it, whatever works. And again, the reviewers are trained that they are basing meeting the requirement on when they completed the primary training. So if somebody completed a primary training in 1999, that is a flag for us, and that is going to be a deficiency, that they are not current in their boards. So again, just pay close attention to that area. And we had a question about when is the next edition of the resources for optimal care of the injured patient due to be published. After the next edition of the resources book is published, it's a continued need for a clarification document anticipated. So I think there's going to be a need for a clarification document, because but again, part of our next revision process is also going to encompass a new PRQ. So we don't have a firm date as of right now, as we are still working on the revision process, and we're still working on the chapters. So no date as of yet. I know there's been some rumors that it may be January or February of next year. We are not there yet. So keep that in mind. So over the course of the next year, we're probably going to still be working on revisions. And again, alongside of that, we are programming or developing a new PRQ, and within that PRQ format or product, if you will, we are going to build in a clarification component. And really what that component is going to be is allow us to tell the trauma center what the expectation is to meet that requirement. So I put an example on here. For example, if the PRQ is asking, is there a trauma surgery published backup call available? The clarification to that criteria would be, when the attending is encumbered, is there a schedule identifying who is on the trauma surgery backup call schedule? I'm not saying that's what's going to be, but something along those lines. So we're trying to build it where it's going to be a little bit more user-friendly and a little bit more intuitive, where we're going to be able to like click on a link that will direct you to the whatever resource color of that book will be, and possibly what the expectation or what we want you to upload, maybe a 3-month schedule to that question, so that way reviewers can see pre-hand or pre-visit what you have, and if they have any questions, then they'll follow up with the trauma center. So again, these are things that are still rolling out. We're still developing these guidelines, and we're still in discussions on how this is going to get programmed, but that is the idea. We've been told that that's how it's going to look. So I'm super excited, given that we've been working with this PRQ for the last 2 decades. So so some new exciting things to come in the near, actually within the next year, we'll have something to roll out for the trauma centers. So with that said, that is going to conclude our webinar today, and thank you everyone for tuning in.
All right, everyone, I want to thank you, Trauma Verification staff, and thank everyone for attending today's webinar for Trauma Verification's August Q&A web conference. Now, if you have any other questions, please contact coTVRC@facs.org. Now, on behalf of Trauma Verification and our presenters, thank you all for joining us today, and also have a great rest of your day.